my fellow pharmacists and colleagues in the space or colleagues to be. I'm really excited to be here. Apologies for the delayed start of my presentation. So I'm delighted this evening, East African time, to discuss antimicrobial resistance. And as Getachew introduced me, with this experience, spanning from clinical pharmacy, public health, leadership, working with several communicable diseases, non-communicable, and also global health security, to mention but a few, including most recently, the COVID and the Mpox work. I'm excited to discuss antimicrobial resistance, which falls around the global health threats, and is also one of the things that have been supported through what we call a global health security agenda. I beg to request you to note down your comments, your questions, so that I go through the presentation and then we can discuss. So I know most of you, all of you know what AMR is, but I would want just to set the context of my presentation and start by saying that, AMR, AMR refers to the changes in microbes that render antimicrobial medicines less effective, and it's ranked as one of the 10 greatest global public health threats. Indeed, an estimated 1.27 million deaths worldwide were attributed to AMR in 2019. And what may shock most of you is that the burden of AMR is actually causing more deaths than HIV/AIDS or malaria. And yet, a lot of the funding that has been coming to, development and public health work has been coming towards the communicable diseases like HIV/AIDS, malaria, TB. I also want to highlight that the burden is highest in low and middle income countries, and we need to be concerned because sub-Saharan countries experience the greatest number of deaths attributed to MR, followed by South Asia. So this graph here just shows what I've spoken about, and you can see that it's only TB that had more deaths than AMR in 2019. What I also want to note is that in 2015, the WHO, World Health Assembly, adopted the Global Action Plan on AMR, and in 2017, several countries, including Kenya, Malawi, Nigeria, developed their first national action plans on containment of AMR. But AMR has been here with us for ages. However, there are now concerted efforts from 2015 with many countries, the early adopters developing their national action plans in 2017 to 2022. And then we are also seeing countries that have even revised. For example, Kenya, where I'm based, we've revised and we have a 2023-2027 version. I will not talk a lot about this slide, but what I want to highlight that since 1940s, when maybe your parents or our grandparents are between an antibiotic, when an antibiotic is developed and when a resistance occurs, are shortened at a very alarming rate. So if you look at the earlier years, there was a larger gap before resistance, kicked in. But most recently, we are seeing, resistance appearing very fast to the antimicrobials. Yet, we don't always have a lot of money or a lot of research going into development of new antimicrobials. What we tend to see, there is more money is going to development of the NCD related products. Of course, those have also really been rewarding to the pharma industry because of the chronic care of those the chronic nature of those diseases. I'm sure you've been taught this and you're aware, but just allow me to recap. One is really over prescribing of antibiotics. And number two, antibiotics is prescribed. Sometimes some use for one day, others use even much longer. Then we are also seeing the AMR is the One Health agenda, meaning animals to human, to the humans. And we see the impact and the reported impact. We tend to report more in the humans. So that unnecessary use of antibiotics in agriculture is not helping us. And we see, like, could give you examples where you see colistin is a reserve drug for use in humans, yet it's being used freely in poultry. Other factors are poor infection prevention control in hospitals, poor hygiene and sanitation practices, and this again leads to even hospital-acquired infections that are resistant in terms of, they are resistant. They have resistant microbes that the available antimicrobials cannot take care of. And then on the diagnostic sides, we lack rapid lab diagnostic tests. We have those, maybe you're seeing that for malaria, for HIV, but we do not necessarily have as many for these other, bacterial infections. So I've used the diagram to recap that. I'll avail my presentation through Getachew, but I thought I should highlight that. And the other thing I would want to also highlight as a factor is poor pharmaceutical regulatory, processes. So when we have substandard falsified and microbials, that's again also, contributing to AMR. Then, of course, when you have poor or weak pharmaceutical waste disposal, there's that exposure to working antimicrobials, and then again that predisposes, resistance in the coming days. Poor hygiene, poor surveillance, and diagnostics are other factors that contribute to AMR. Then why should we worry about AMR? If I had a lot of time than what was allocated, I would give you many case studies and personal stories. But believe you me, AMR affects all of us. It's just that there isn't a lot of data that has been documenting why so many of people we know in hospitals have died in, ICU, HDU, surgical wards due to resistance, and, even staying there for so long, being hospitalized and incurring a lot of costs. I have a personal story, a close relative who through MR ended up, being in ICU, back toward HDU. And by the time she passed on, the bill was way above 10 million Kenyan shillings. And, I can identify with the AMR at a personal level. But it is a global public health threat and there are consequences. Of course, one of those is treatment failure. And that's alluded to the example I've given you, where you have increased morbidity and increased mortality. Then, of course, if you're being treated and you are not sensitive to the available products, you are not productive at work and also, economically. And of course, by you staying in hospital for so long, using expensive, more and more expensive antimicrobials, there's increased treatment costs. The other thing is we have limited therapeutic options. I mentioned that new antimicrobial agents and are few and also far from development. And then there's, of course, the local and the global economic impact of antimicrobial resistance, where you have, contracted labor force, you have reduced agricultural yield, reduced, animal production, and economic inequity. So on the side, that was also alluded to in the graph I presented before. So I talked about gains that have happened since 2015. And WHO had produced a generic global action plan on prevention and treatment of antimicrobial resistance in 2015. And through this global action plan, and if you can now allow me to call it GAP, and for the country ones, allow me to call them NAPs, National Action Plans, countries adopted the Global Action Plan to have their own, which are implemented through a One Health agenda. It's not a human health problem, it's not an animal health problem, but it's a problem for human health, animal health. We are looking at agriculture and also environment. And that's why the GAP and AMR globally initially was being led by the tripartite, WHO, the OIE, that's the one for Organization for Animal Health, and then also FAO, that is the Food Agriculture Organization. But increasingly, because of the environmental issues, the environment people were brought on board. That is the UNEP. And that is the approach for containment of AMR. So there are 5 objectives, and these objectives, I want you to take note of them, because when I start talking about opportunities for you as pharmacists, for you as IPSF members, they will fall along these objectives. One is improving awareness, understanding of AMR through effective communication, education, and training. The second objective is knowledge and evidence-based through surveillance and research. Then there's the third one, which is really around infection prevention and control measures. The fourth one, optimizing use of antimicrobial medicines in human and animal health. And the fifth one, need to have economic case for sustainable investments, because even as we've argued over the years about AMR being a burden, needing resources, we don't have a lot of economic cases, a lot of studies that show the economical gaps, the economical consequences of not tackling antimicrobial resistance. So just to give an example of a country national action plan, and also the other countries are along the same, Kenya also had the 5 objectives in 2017 to 2022. But in 2023, and I'm happy to note that through the organization I was working for, Management Sciences for Health, and the program that I was leading, which was called the Medicine Technologies and Pharmaceutical Services Program, I supported the review of that National Action Plan of 2017 to 2022 to develop the 2023-2027. And we introduced a new objective, which is highlighted in red, to strengthen governance and coordination mechanisms for containment of AMR. And these governance structures are One Health structures. They are multi-sectoral, they are multi-stakeholder. They have those key stakeholders that have been involved: animal health folks, human health folks, agriculture folks, and the environment folks. So as an example, just to show the traction in Kenya, as an example, is from 2016, a lot has been done containment of AMR. If you remember what I've just shown you around the objectives, in that AMR, if I summarize, there is one for awareness knowledge, there is another one for surveillance, AMR surveillance and research, another one for IPC, infection prevention control, then on microbial stewardship, and the last one on economic case. So in Kenya, there have been the first NAP, which I said was revised in 2023. We, as a country, we supported the national IPC strategy, policy, and guidelines to support implementation of NAP. There's importance of having antimicrobials classified by access, watch, and reserve categories, what you call WHO aware categories. And so in Kenya, through the National Medicine Therapeutic Committee, were able to review the KML, Kenya Essential Medicine List, categorized antibiotics by access, watch, and reserve, categories to ensure that we could promote prudent use of antimicrobials. Another thing that was done was development of the NAP AMR monitoring and evaluation framework that was launched, and it was a first. In fact, I would say Kenya, for the KML by Aware and the MNE, it was the first country within the continent. Then, of course, further unpacking those objectives and coming up with relevant documents and strategies. For example, having national microbial stewardship guidelines, having an AMR surveillance strategy for objective 2, having the IPC guidelines for objective 3, and then having also AMR consumption data, and again to support proper use of antimicrobials by having, like medicine formularies that adopt access, watch, and reserve categories. And we are seeing that in Kenya, the Kenya National Medicines Formulary, and many other countries have these kind of documents. They have, One Health governance structures. They have committees for driving each of the objective, a committee for IPC, committee for antimicrobial stewardship, committee for AMR surveillance, so that they are concerted efforts to really contain AMR. And AMR is the silent pandemic. If we don't do anything by 2050, we are seeing where, we'll be having to spend a lot of money every year to tackle resistance microbes. So, in spite of the gains and the gains that countries have achieved, and also the globe at large has achieved, we still have prevailing challenges for combating antimicrobial resistance. One is resource limitation. You heard me talk about how much goes into HIV, AIDS, and malaria compared to AMR, and yet in 2019 we had more deaths from AMR. So resource limitations, less funding towards containment of AMR, and yet we know AMR is a global health security. It has no boundaries. It will cross the borders and move from one country to the other. It is also coming from the environment to the plants, to the animals, to the humans. The other thing is data gaps. We lack comprehensive data on AMR. And so it's very hard when you don't have data to argue and even mobilize resources. And when you don't have data, you are not able to track and respond well to resistant patterns, which we even see maybe in the places we work, in the hospitals we've gone to, we will find the labs are weak. They are not necessarily undertaking a diagnostic stewardship. There's a lot of empiric use of antimicrobials, antibiotics in our hospitals are not guided by the lab resistant patterns. Then behavior change is another problem. It's very hard to change prescribing habits and the public behavior. And this requires a lot of awareness creation and education. I don't know in your different countries if you've seen when a medical rep has gone to see a particular doctor, and soon after, that doctor is just prescribing what was detailed to them by the medical rep. So behavior change is a key thing that needs to really happen for us to stop using antibiotics in a non-judicious way, inappropriately. If we have prudent use of microbials, we are going to curb AMR. And I would want to convert all of you on this call, even in your individual, places and spaces, you become an antimicrobial steward and push for prudent use of antimicrobials. There's also limited coordination, communication between sectors. Indeed, before this One Health agenda and approach to containment of AMR, the different sectors were operating in silos. I gave you the example of colistin. It's a reserve drug on one side of the human health, and on the other side, we are seeing it being used liberally. There's also limited awareness, education on sustainable practices. Then we have fragmented healthcare systems. Cultural practices continue to be an impediment. There is inequity in access to healthcare. And so sometimes because of this inequity, people cannot access the right antimicrobials, the right antibiotics, the right antifungals and antiviral agents that they need so that we manage the AMR menace. There's limited lab infrastructure. Surveillance of hospital-acquired infections remains a challenge in many countries, and it's even worse in sub-Saharan Africa. And we have weak legislation and regulatory frameworks. A lot will still need to be legislated and well regulated so that, for example, we can have better control and use and selling and dispensing of antimicrobials even in the retail pharmacies. Weak wash infrastructure, and then also we find competing priorities of staff. At facilities, we have very few health workers compared to the workload, and they are pulled in multiple activities such that, they relegate AMR and IPC efforts, to the backstage because they're always, they're overworked and basically they are working on the high priority urgent items. But in those challenges, my dear fellow pharmacists and pharmaceutical staff, and for me, I see challenges as the reason we exist as human beings to tackle those challenges. So those challenges, provide priorities and opportunities for AMR containment. And they also provide priority and opportunity for you as IPSF members. Now, as students, it's good we have AMR taught in our, training curricula. It's good you get exposed to AMR containment efforts as interns, and there are opportunities that you can tap into post-graduation. So the priorities include strengthening AMR surveillance, and don't say that is for laboratory scientists, even as pharmacists. There is an opportunity. Promoting rational use of antimicrobials is another opportunity. Improving infection prevention and control practices is another opportunity and a priority. Then we also need to advance research and development, especially to come even up with that economic case, but also to inform timely decision making. We need to strengthen healthcare systems. That's a priority. We need to address AMR in agriculture. Often the problem is not seen in those plans. It is seen as it comes through animals, or as it goes to animals, or comes to us as human beings. So we need to address that AMR in agriculture. There is need to strengthen the One Health AMR collaboration and partnerships. And this is not just at global level. At global level is happening very well. At country level, we need to have that. At subnational level, we need to have that. We need to work closely with our counterparts in the animal, agriculture, and environment sectors. And then we need to enhance public awareness and education and create greater partnerships with the private sector, professional associations, civil society organizations, and academia. I'm happy to note that in the previous project that I was involved in, we actually introduced an AMR and microbial stewardship content curriculum at the University of Nairobi School of Pharmacy. Because when you introduce things in academia, you reach out to many more students and people come out when they are practice ready. You know what AMR is. You know how to deal with it, and you have the passion already. And when you get employed, people are not teaching you at the workplace. Then there's the need to forge collaborations. There is the need to establish sustainable AMS at all levels, and also embedding AMR within education. I've talked about that. Embedding AMR in primary schools, secondary schools, within the community health strategies, and we need to increase the pool of AMR experts. So if we are increasing that pool, you must join that pool of AMR experts. The other thing is really to enhance surveillance of AMR, including antimicrobial consumption and antimicrobial use. Moving on, priorities still continue to show up. We have the need to embed monitoring evaluation in ability or at the national level. We can upgrade infrastructure to ensure that AMR data management systems are there to inform us in our decisions. Then I'd mentioned a gap around regulation and legislation. There is another opportunity where we need to strengthen regulatory frameworks, pharmacovigilance. We also need to link AMR to universal. AMR, you cannot achieve the SDG goal 3 and universal health coverage if you've not, dealt with AMR, which is both safety, quality, and you cannot have healthier people without curbing AMR. So the opportunity here is, if we want money for AMR and support where we work, then you need to align it to the big things at a country level, that are priority at a country level, are priority at a national level. If UHC is the agenda, then you need to ride on that. We also can integrate AMR. I mean, when you look at tuberculosis, we have seen, MDR TB, XDR TB. That is resistance. When you've seen resistance to antimicrobials, resistance to antimalarials, that's AMR. So we can really talk about linking and, aligning AMR to also other diseases, so that you tap into those resources to contain AMR. And again, linking AMR containment and IPC with global and national health security and pandemic outbreak preparedness. We saw, like in this country and a few other countries, with COVID, there was liberal use of azithromycin. What could have happened to azithromycin? Because there was a pandemic and that was seen to work and it was being utilized, in some places. The other place, when I look at use of antimicrobials, and I have done a lot of facility work, we see liberal use of vitamin C. There is the vitamin C, which is the C, but then there's also this other C, which is ceftriaxone. When we've been using ceftriaxone, for everything, then again, we are predisposing it to resistance. Then the other priority is focus on AMR efforts across the different sectors, as I've said. So these opportunities, these priorities should also be your priorities and opportunities. Should keep you thinking, hey, as I leave college, as I finish internship, as I get out there, am I interested in MR? And what area can I tap into? Which objective can I support? At what level? Is it national level? Is it at a facility, subnational level, district level, county level? Is it a facility? Is it in the industry as we manufacture more and microbials? Is it at the regulatory authorities where I'm supporting regulatory frameworks? Where can I add value? Or is it in academia I go back and, make sure that AMR is strongly covered in our pre-service training curricula? So I put this in red so that it sticks, and just know that you have a big role to play at global, continental, regional, country, subnational health facility, community levels, in the retail pharmacies, across the different sectors of public, private, faith-based sectors, and even you can work within the One Health space, the zoonotic disease units, the human health, the human health space, which we are of course very comfortable with. You can go and work in the, in WHO. You can go work in FAO, Food Agriculture Organization. There are opportunities in there as long as you align well. So as I conclude, AMR is a significant global and local health threat that requires a One Health approach and concerted efforts from governments, healthcare professionals, research, the public, students, and other key partners. By us understanding the causes, the impact, strategies to combat AMR, we can work towards a future where AMR is effectively managed, controlled. What I want to say is that we need to implement sustainable, integrated, systemic interventions across sectors and at all levels. The piecemeal has not worked very well, where you've had the silos. But when it's concerted across sectors, across the levels, and people are speaking, there is that continuum of care in terms of prevention and treatment of resistance. And prevention is better than waiting for resistance to kick in. So as IPSF members, you need to join others in curbing AMR. For example, and I've mentioned it before, in implementing selected objectives of the AMR national action plans in your different countries. Thank you very much, and over to you. Apologies again for starting late.